On behalf of the Executive Committee and our President, Jim Martone, I'd like to welcome everyone to the Connecticut Society of Eye Physicians and Ophthalmic Mutual Insurance Company program on risk management. Tonight, we're going to hear from Bradley Foraker. Dr. Foraker completed his residency at the Oceaner Foundation and Clinic in New Orleans, Louisiana. He then completed his fellowship in cornea, external disease, refractive surgery, and research experience at the University of Oklahoma Dean McGee Eye Institute. He's an AAO Honor Award recipient for his contributions to ophthalmology, and he currently practices in Brandon, Florida at the Florida Eye Specialist and Cataract Institute. Dr. Foraker.
Well, thank you very much. I can't tell you how much I appreciate your inviting me, and I want to thank Deb especially. You all have been phenomenal over time, and I've had the pleasure of coming up and speaking with you in person before, and look forward to that occurring again. I need to go ahead and share my screen, but I would need Dr. Lim your help in doing that, I think, or whoever's hosting it, or maybe it's Deb.
Yeah. Deb, can you hand over the screen? Right now?
Okay, I think we're heading there. Good. All right, great. Thank you so very much. Hope everyone can see my screen and what have you. And like I said, I've worked with a lot of societies. I've worked with a lot of different groups. I've been past president of the Florida Society of Ophthalmology, and I can't even begin to tell you how very fortunate, which I'm sure you already know, you are to have Deb Osborne there to help guide you and speak for you, and her relationships with the various individuals has just been fantastic. And I think we're all very appreciative of Kathy Cohen and the spectacular work she does in Washington to keep things organized and keep them moving for all of us. We've certainly done much better than a lot of the societies, and I think it's in large part by the contributions to the Surgical Scope Fund and to helping out the AAO and their efforts to be able to achieve these different issues. And I appreciate having Hans Brunn on this call with me. Hans has been a risk manager at Omic for many, many years. He's not only knows the subject area extraordinarily well, but certainly has fielded hundreds, if not thousands, of phone calls from the various members of Omic regarding the difficulties that we've had. So I will look forward to his insights and chiming in as we go along. But I would also invite any of you, if you have questions, please don't hesitate to contact. Just raise your hand or make some sort of summon, and I certainly will recognize you and or just chime in and ask your question. I know this will be kind of a hot area. So what we're talking about tonight are lessons learned from cataract surgery. And if you're a non-cataract surgeon and don't participate in surgery at all, for instance, there's still a lot of pieces of information, I think, in this talk that will be applicable to you. And I think things that you'll learn from the discussion is about consent, about how to speak to the patient, about how to maneuver. So we have a lot of things, I think, in this talk that'll be applicable to anybody, even if you're not a cataract surgeon. Let me start by saying I am a consultant and speaker for Alcon, and obviously I've been a board member for Omic for almost 15 years now. So it's been an honor to work with this group of individuals, and I think they've served our academy and our ophthalmic community well. We have several learning objectives, which I've just quickly outlined. But let's talk about the Omic claims history from 2011 to 2020, which is about the last 10 years. Important to come out of this is the fact that about 80% of all the claims close with no indemnity payment. That's a large number, and it may be that these are people who didn't go forward with their claim, or people that after we reviewed their claim, suggested to them that there was really no basis. So it's an important thing that should give all of us some comfort. And I think a lot of that comes from having individuals involved who are very familiar with the various areas of ophthalmology and can certainly review claims and tell quickly which are legitimate and which ones are in fact not very legitimate. The average settlement is about $226,000. The important thing to take away from that is that we do have to settle some cases, probably between 16 and 17% are settled. And most of the time they're settled for what I think are probably reasonable parameters. And I would also suggest to you that that's not the whole picture. The cost of litigation, the cost of getting expert witnesses, the cost of going through all this process is really quite high. And so in addition to the $250,000 in settlements, consider the cost of actually litigating. We recently had a case in the Washington State area that went all the way to trial. And fortunately, we were able to succeed in trial, which is the case about 90% of the time. But it still cost over $400,000 to obtain the expert witnesses and go through all those, all of the trial procedures. As far as cataracts are concerned, about 83% of those close with no indemnity. And again, the average settlement's about $150,000 on those particular claims. The highest claims that we have are those in pediatrics. They don't occur often, but they're quite expensive when they do. Now, let me start by giving several examples, and all these examples come from our files. These are cases that are closed, but they are cases that we've worked through over the years, and they give us some flavor for various issues that might come about and create a problem. The first one is wrong IOL. As you all understand, wrong site, wrong IOL surgeries continue to be a bit of a problem. We certainly have made improvements on that with our timeouts and working through various procedures like that. But still, the orthopedic surgeons and the ophthalmic surgeons still rank 1 and 2 on having these difficulties. And in this particular case, a 65-year-old female patient came in with some blurred vision for about 6 months, right eye more so than the left eye. Uncorrected visual acuity is only 20/40 in each eye, and she had a 3+ nucleus sclerotic cataract. The plan was to do a phacoemulsification with BCIOL in the left eye, which was done with no noted complications. The lens implant indicated that she had a multifocal lens at 25.5 diopters. That was the one that was supposed to be implanted. The documentation clearly indicated the patient's choice of multifocal lenses. The phaco and posterior lens implantation was done. And it turns out that instead of a multifocal lens, which is what the patient requested and what the consent indicated, as well as the notes, she had an implantation of a monofocal lens. There was really no mention in the op note of any complications or any reason for the monofocal lens implant. The lens order, the requested lens for the case, was a multifocal lens. And the patient was seen on day 1 with some visual improvement by pinhole in the left eye. She was still 20/40 uncorrected, but she had a pinhole vision of 20/25. The lens looked to be in excellent position. She was asked to return in a week. There was apparently a handwritten addendum that was dated post-op day 1, but there's some question as to exactly when this was actually performed. And the reason I bring that up is that although sometimes people will look back and realize that they've had an error or an issue, they'll end up by dating the note for those issues when they think it should have been in fact inserted in the chart. realized that the most important thing for us to do is if you make an addendum, it's fine. There's no reason you can't make an addendum to the chart, but always notate the date at which you enter that into the chart, not when you think it should have been entered, but when you actually do enter the information into the chart. It was noted that the checklist was done, verified the lens, but it was realized that there was a wrong lens inserted into the eye, although this wasn't discussed with the patient at the time. That the explanting the lens would be a problem because there was too much posterior pressure, and it was felt that if the lens were to be explanted, there is a chance of the posterior capsule rupturing, causing the increased risk of retinal detachment and macular edema and all the other complications we realize are related to rupturing the posterior capsule during surgery. It was decided it would be best just to leave the lens in place, the monofocal lens that was placed in the eye by mistake. The ongoing care, the patient had complained of some blurry vision at week 1, at week 5, seen by the optometrist, and noted again that she had blurry vision, was disturbed by that. And then at 5.5 months was seen by the insured, and for preoperative evaluation for cataract surgery in the right eye. She consented for cataract surgery in the right eye. The plan was again to put a multifocal lens in the eye. That was accomplished. She did have a multifocal placed in her right eye without difficulties. She was seen on day 1, again complained of some now blurry vision in her right eye, 20/70, pinholing to only 20/40. The vision over a period of time seemed to be difficult to improve. She did change ophthalmologist, and her ophthalmologist, the new ophthalmologist, indicated that she may need an IOL exchange. Her visual acuity without correction was 20/70. She pinholed only to 20/50 in the right eye, and the left eye she pinholed only to 20/40. 7.5 months after the wrong IOL was implanted in the left eye, and it was noted by the surgeon that although the patient had been charged for a multifocal IOL, she had received, in fact, just a monofocal IOL. She received a refund check of $1,820 for out-of-pocket cost, and no real explanation from the physician, no discussion by the physician, just here's your refund for the mistake. So that prompted a records request with a notice of intent to sue. So a claim was made at that particular point in time. The addendum apparently was made 7 months after the event. It was not made the day after the surgery, although it was dated on that day. And again, I would caution you, that's a real red flag. Juries have a real tendency to trust physicians. They like physicians. As Senator Blumenthal had indicated, they're appreciative of the work that we do. They realize that we're trying to work in their best interest, and all of that's evaporated if it can be shown that the medical records have been altered. That really is a terrible red flag and a difficulty for all of us. The insured did not, in fact, disclose the error to the patient, and so there was a claim of fraud and intentional misrepresentation. The error was actually discovered after the second surgery on post-op day 1, when the insured's partner stated that during an exam with the patient, you do realize you have a monofocal lens in the left eye. To which he said, I hope that's not true because I paid for a multifocal. So inadvertently, he is the one who suggested there was a problem. So the physician involved, the surgeon involved, indicated that the monofocal lens was incorrectly loaded, whereas the multifocal lens should have been in the given to him instead, and so he just placed in the eye what he was given. The problem with that is this particular lens comes preloaded. And so it would be unlikely that that would be the case. The monofocal lens should have been removed immediately and replaced. That was at least the supposition. It certainly is reasonable for the physician to decide not to do that, but that would be the supposition. And it probably is not advisable to remove the lens after 13 months. Now, one of the questions that has come up previously and should be asked in this particular case is, would there have been any difficulties, any cause to notify the patient if in fact the monofocal lens had been removed at the time of surgery and the correct lens placed in the eye? And so, after much discussion with the various folks at Omic and our experience in the past is that you still have to disclose to the patient that an error had been made if you place a lens in the eye, even if it's immediately removed and replaced, because of course we all realize it did put the patient at some additional jeopardy. The Omic review by our surgeons was that the first surgery, the lens implant, a monofocal, was mistakenly placed in the eye. No documentation or discussion with the patient was made, no documentation that the surgeon discussed treatment options with the patient regarding the error. And a lot of that's because I don't think that he was fully aware of it. And when you give a refund, it's probably better to discuss with the patient why you're sending it back to them. There was a clear case of liability. Omic was able to mediate the case and without further difficulties, and the case settled for $150,000. So it was really pretty reasonable. Now, what were sort of the lessons learned from this? Because we always try to go back, sort of like near misses with airplanes. We always try to go back and analyze what were the problems and how can we provide that information to groups like your great society and provide that information to our colleagues so that we don't constantly make the same problems. And one of the things that we noticed that preoperatively, we want to make sure the right lens is ordered and that right lens is on the table. And of course, that's part of most of our safety checklist in the operating room. We want to recognize what lens we intend. We usually call out the power. We usually look at the power to make sure that lens is in the room and available to the patient. We try to take all the other lenses out of the room so that we don't end up with an errant lens being placed. Intraoperatively, of course, you do the best you can for the patient. It would not have been inappropriate if the surgeon felt comfortable to remove the lens and place the proper lens. There's certainly nothing wrong with that. And on the other hand, if he felt uncomfortable with that situation and felt there was too much posterior pressure, it's certainly not unreasonable to leave the lens in there and then at some future time, just preferably the next day or that day, discuss that with the patient and their family and make a plan to further evaluate and change the issue. Postoperatively, of course, a thorough, accurate, timely op report should be done. You should disclose what the problems are. And factually, in a timely disclosure of the error to the patient, it's always better for the patient to hear from the surgeon that there's been an issue, that there's been a problem. And then I think it helps the rapport and keeps the trust in the physician if you can then discuss what are our options for remedying this issue. The documentation and the medical record being placed late is certainly not something we should ever do. Now, when is it appropriate to offer a refund? Waiving fees or refunds is certainly very legal, and it's in fact not admissible in most courts. So you can provide a refund. It doesn't hurt you. It doesn't hurt your case. It's not necessarily a admission of doing anything wrong. Hopefully by that time you've had at least a discussion of the issues with the patient. It may appease the patient. It may be seen as fact that you care about the patient, that you recognize there's a difficulty, and that you're willing to step up there and try to help in the particular situation. It is always a question regarding the refunds of if I give a refund, does that have to be then reported to the National Practitioner Data Bank? It's generally considered that if that refund comes from your personal funds as opposed from your corporate funds, that it does not have to be reported. Of course, if there is an error, that may well end up being reported to the National Data Bank, depending on the rules and laws of your particular state. In Florida, putting in a wrong IOL would need to be reported by the surgical facility as well as the physician. You have a duty to self-report, and then it's taken up by the board and considered from there. And in our particular state, should you have 3 errors that are determined by the Board of Medicine to have occurred, then your license is permanently revoked in the state of Florida. So we're one of the states with the 3 strikes and you're out issues. You can always contact the claims of whoever your carrier is, if it happens to be Omic or others, and discuss the issue with them. And should you discuss with them, should you have a refund? If you do give a refund, how should that be related to the patient? How should you discuss that with them? And make sure that if you find that you have to send the patient somewhere else for treatment to another physician or another facility, that you have those fees billed directly to you and paid by you. As mentioned here, this ensures that the payment will only be for the medical things that you've brought forward. Any questions or comments about that, about this issue? Anybody have any questions? Okay. Let's go to a next case on refractive error. And refractive surgery is broadened. It used to be refractive surgery was only when we considered RK, for those of you who remember RK, AK, LASIK, PRK, all those types of things. And that was considered to be refractive surgery and much different than cataract surgery per se. Nowadays, of course, refractive surgery has moved into the cataract realm. And a lot of the principles that applied to doing refractive surgery now apply to cataract surgery. Importantly, patient selection is critical. Importantly, making sure that the patient expectations are not excessive and that they can be met and that they're agreed to prior to surgery. Those are all very important points, and we'll talk about that. This was a patient who was referred for cataract surgery by an optometrist. There are multiple entries in the record. The patient did not tolerate monovision. And in fact, the patient made a very clear discussion of the fact that they wanted intermediate vision, but did not want monovision. The plan was to do a femtosecond assisted cataract surgery with a lens that would correct for some of the astigmatism. Now in this note, you can see that the cataracts have been noted as 1 to 2+ in the right eye, 2+ in the nucleus correcting cataract in the left eye. But also note in this EHR record that the clarity of the lens was clear. We should all be very careful about having preloaded data and not correcting it, because obviously if the lens is clear, there's probably not a lot of reason to do surgery. It is noted down there though, and this is in the medical record, the patient does not tolerate monovision or has not tolerated it in the past. On the actual informed consent, there's an option to choose monovision IOL, and the patient did not indicate that was something they wish to have done. And so that's important. Post-operative course, day 1, the optometrist saw the patient, Didn't notice any problem. Day 3, insured saw the patient. The visual acuity at a distance was only 20/60, which obviously for all of us, and if there's no other reason for pathology in the eye, we would wonder why their vision was off a bit. J1 was, they could see J1 vision at near, and their refraction was a -1. And so it was explained to the patient that by the surgeon that his plan was to offset their power by 1 diopter to allow for monovision and reading. And that the right eye would be set for plano at a distance. Right eye, the surgery was accomplished, and true line lens was placed. Post-op day 2, vision in the right eye was at a distance uncorrected 20/30. At 1 month, the patient was complaining of constant tearing, and I think this is important for all of you who've done refractive surgery in the past. When you have a patient who comes in with a plethora of complaints, it always raises sort of a red flag for us. She's complaining of constant tearing, burning, poor vision. She had dryness in the eyes as you look through the record, stabbing pain in both eyes for several weeks, and that the distance vision was blurred. And the refractive testing revealed regular astigmatism. The diagnosis was residual refractive error in the right eye and myopia in the left eye. And to treat that, the plan was to do a YAG capsulotomy in the right eye in a month, and then follow that at some point in time with a PRK to fine tune for distance. Again, not addressing the issue of the monovision. Then this was the this was the entry note by the physician at the time of the YAG capsulotomy. 72-year-old female complains of patient returns for YAG caps laser treatment in right eye for a few months. The timing is described as constant. Quality is worsening, severity described as moderate. Of course, we all recognize this as being a fairly common EHR setup to make sure that we cover, from a historical standpoint, the important points for CMS. But at the same time, it just doesn't make a lot of sense. And so I would suggest to you that you have to really be careful about how you document. Be careful of the information that's placed in the EHR to try to make your life more convenient, and make sure that it makes some sense if someone were to read it, because that certainly doesn't. 4 months post-operatively, distance vision was constantly blurry, no improvement after the YAG, which isn't tremendously surprising. Artificial tears were then added, and the patient was offered a PRK. The corrected visual acuity was excellent at 20/25 with a very mild myopic prescription, but the patient was bothered by this whole issue. The patient was to consider returning for a PRK in the right eye, but never did return. Of course, a claim was made at this point. What did the patient understand? The doctor told me the cataract surgeries with intraocular lenses would correct my visual problem with both reading and distance, and I would no longer need corrective lenses. We all know that that's unlikely to occur by just correcting with a lens that's not refractive in nature, an accommodative lens or such. The lens charge apparently was about $4,500 each. The insurance, of course, did not pay for those out-of-pocket expenses. And the doctor, and I think this is the key point, the doctor convinced me that I know not only needed them, but I would have good vision for distance with and reading without glasses. The reason I bring this up to you is to talk just for a second about, again, patients who are having refractive surgery. For all of us that have done a fair amount of refractive surgery, we know that it's critical to not overpromise and underperform. That really anchors patients, and they'll share their lack of enthusiasm for your care with many, many people in your waiting room and outside of it. And so it's important that the patient understand exactly what you're offering and what the expectation should be. And if they don't, if they, for instance, come to you and say, so if I have this multifocal lens, then I'm never going to need to wear glasses for distance or for near again. That's a patient probably would be better to have a discussion before surgery about their expectations, and that you can't promise that of anybody, so that you're having this discussion prior to surgery rather than unfortunately having it after surgery, which becomes almost an appearance of self-serving, and again loses the faith of the patient in your care. So I would be careful, because many of us have folks who will make comments to the patient, or technicians or surgery schedulers. Some of the busier practices now have gone to having the surgery schedulers incentivized to try to convert patients to do additional procedures or additional options that are offered to the patient for their good. But I would always suggest that you make sure that the last person that the patient has contact with regarding the consent is you, and that their expectations and what you're able to deliver match up, and that the patient understands what you're offering them and how you can try to help them. That's really critical. The original surgical plan was for a Trueline IOL. But the surgeon instead chose to do monovision, although of course it was stated in the chart the patient doesn't tolerate monovision. There was no documentation to support the thought process of changing the plan, and the patient did not indicate the lens choice on the consent form. So the patient certainly wasn't aware that this was going to occur. The actual settlement ended up only being $3,500, and which I think was really very nominal and was very fortunate in this particular case. It could have been much higher. Again, when we're talking about informed consent, it's an oral agreement. There are a number of institutions that didn't even have written informed consent years ago. Because it was an agreement between the patient and the surgeon about the risk, benefits, alternatives, and potential complications, as well as the consequences for refusing treatment. The informed consent, as a written document, is there principally to memorialize the conversation, and there hopefully it is procedure specific, although not always, and those specific procedures and their consents are actually provided to anybody on the Omic website. At least ones that we suggest are fairly strong and would help protect you. It's also important to note in the medical record that you've had this discussion, and any nuances that might have occurred. That'll help jog your memory prior to surgery. It'll also serve to back up anything that you understood from the patient and the way that you had interpreted their discussion. It doesn't always explicitly, the consent is different than an agreement, because it doesn't always explicitly state what the goals are. There are certainly individuals who notate in their chart that the goal is to end up at a minus 0.50, 0.75, 0.1. I would be a little bit cautious about that issue. We've certainly seen cases at Omic where patients, it was written in the chart that the goal was a 0.5. The patient ended up with a 0.75 or a minus 0.1 or 1.0, and filed a lawsuit because they were greatly grieved by the incorrect power that came out. All of us know that's ridiculous. but there are certainly a number of individuals out there who would be more than happy to take that case and try to earn some dollars. What happens if you and your patient have different goals and expectations? For anybody who's done refractive surgery in the past, I think all of us know the answer to that, which is allow that patient to go to somebody else. They might be able to explain the goals better, or somebody who might be able to have a better understanding of what the patient's trying to achieve. But I think if your goals don't match, you're better off preoperatively letting that patient go to someone that uh, can deal with their unrealistic expectations and to avoid that. So please make sure, it's really critical that the patient have reasonable expectations. And again, if the patient's goal is unattainable or contraindicated, the document the patient's understanding of likelihood of success, complications, and impact on activities of daily living. In our state, one of the things that I did as president of the society was get the medical board to approve a cataract consent form, which states all of the potential side effects. And if in fact the patient does sign that consent, then the jury, if it ever goes to trial, is to be notified by the judge that the issues on the consent form are considered to be complications, not adverse reactions, and that they should treat them as such, which really has made a big difference. No documentation of the surgical plan would be similar to monovision that the patient did not tolerate. There is no documentation of the patient's acceptance. Did the patient understand how monovision would impact the daily life and activity? Obviously not. And prior to discussion with the patient, what the goal is not reached. That's the other thing that's I think helpful, is the discussion that the physician has with the patient regarding expectations is very helpful preoperatively, so that if the goals aren't met, at least the discussion can be said that, this isn't self-serving, but we had this discussion prior to surgery, and your expectations should have been aligned properly. Recently, I had a patient that I had a high likelihood, in my opinion, after a corneal transplant, of needing to have a valve implant or have glaucoma problems nonetheless. And I discussed it with the patient, went over it thoroughly. Patient postoperatively did have a number of difficulties from a glaucoma standpoint. Finally decided that a valve must be put in. And one of the things that made me feel at peace was when the patient said, we had this discussion prior to surgery. I fully well knew that this might have to happen, and I was hoping it wouldn't, but you warned me that this is something that might have to happen, so I was fully anticipating it. That makes for a good relationship and also makes things easier going forward. Any questions or comments before we go on to the next case? This third case is really pretty straightforward. It can certainly happen, unfortunately. The misfiled A scan. I had two patients with the same surname walk into the office on the same day for evaluation of cataract surgery. 8 scans were performed. Patient 2's A scan, unfortunately, was misfiled in patient 1's medical record and was used to calculate the measurements for the lens implantation. No one picked up on the error. No one checked it to assure that the patient name and date of birth were correct on the A scan measurements. And so when the patient went to the operating room, they unfortunately patient 1 received the lens implant that was initially meant for patient 2. The post-op day 1 exam was done in the surgeon's office by the co-managing OD. It was not the surgeon in the office at the time. and the patient was found and refracted to be hyperoptic. This was never communicated to the surgeon. And I've seen a number of these cases at this point where there's a lack of communication. And all of us, I think, should understand, whether it's a colleague seeing our patient or whether it's a co-managing optometrist, that we all have a pretty good idea of what we'd expect to happen after cataract surgery. And if you get a hyperopic surprise, it's important to communicate that. I've seen some cases with TAS where there were 8-10 patients who had cataract surgery. The surgeon had no idea that TAS was going on. Went ahead and operated again on about 8-10 patients a week later, within a week. And then all of a sudden started getting reports about all the problems the first set of patients were having. Of course, had the same problems in the second set. So communication is really critical. 2 weeks later, the surgeon, unaware of the hyperopic surprise, performed cataract surgery in the second eye using the same misfiled A scan readings, which of course resulted in the incorrect IOL being placed in the second eye. The patient was seen exclusively by the co-managing optometrist. After surgery, the surgeon remained unaware of any problems until the patient returned 2 months later after the second surgery, complaining of poor quality vision. The medical record documentation of the surgeon's discussion with the patient regarding the need for IOL exchanges is obviously important. The record is silent as to whether the error was disclosed to the patient. Fortunately, the patient's ultimate vision was quite excellent with that correction after the IOL exchange. So the patient agreed to an IOL exchange. It's not clear that they understood exactly why they needed an IOL exchange, except they had poor vision. But it is fairly clear that they didn't realize that the surgeon had actually put the wrong IOL in because of the incorrect calculations. Patient demand was for $95,000. It settled for $36,000, which was very fortunate. Obviously, human error. Several issues contributed. Systemically was the misfiled A scans, inadequate safety checks within the office and in ordering the lenses. And of course, I think just as importantly, the communication between the surgeon and the co-managing individuals, which I think is critical and probably would have stopped the second implant from even occurring. It's important to have a good preoperative protocol for surgery scheduling. It's important to confirm that the correct devices are ordered, received, and sent to the OR. Managing changes to surgical plan, communication among the patient, staff, surgeon, critical. Documenting any changes in the medical record, important. And then determining whether there warrant additional discussions or informed consent with the patient. Obviously, it's always important in order to maintain that physician-patient relationship that they trust the surgeon. And so I think that providing information, carefully documenting it is critical. And it's important that the co-managing optometrist is qualified to co-manage the surgical patient. They're knowledgeable about the complications. And I think just as importantly, knowledgeable about the complications, they ought to be knowledgeable about what your typical patient looks like on day 1 postoperatively or day 5 postoperatively. Is it common for your patients to have 20/70, 20/80 vision day 1 or day 7 or day 14? And if not, why? And make sure that any complications are sent quickly. And of course, we know that that's one of the standards in the paper that's put out, the joint paper that's put out by the ASCRS and the AAO on co-managing. One of the critical issues was the communication, and that the co-managing individual needs to send information promptly and frequently to the surgeon, and that if there are any difficulties whatsoever, that the patient be sent back and that be communicated to the surgeon. Any particular comments? Hans, do you have any comments regarding this issue?
No, I don't. Not at this time.
Okay, well then let's move on to our fourth case, trying to be cognizant of the time. And this fourth case is a peribulbar block. The insured performed a non-eventful cataract surgery on a patient's left eye, no problems whatsoever. A week later, went to perform cataract surgery on the right eye. The procedure was done at the ambulatory surgery center. Peribulbar block was placed with monitored IV sedation, and there's no report of any complications with the peribulbar block whatsoever. The patient left the PACU about 10 a.m. The PACU nurse tried to call the patient a couple hours later, but couldn't reach him. But around 5 o'clock, the patient called the office to report pain in the right eye, headaches, discomfort, and of course, had already had the left eye surgery performed, didn't have any of those problems. So recognized that there was a problem here. That individual was told by the COA to remove the patch, go ahead and start the Pred Forte and the Ocuflux, and use some Tylenol number 3 for pain. 2 hours later, the office, to the credit of the office, called the patient and asked how they were doing, and the patient reported painful, swollen eye, appeared black around the eye. And of course, most of us understand that after cataract surgery, we hope our patients don't have a black eye. That would not reflect well upon us, and in fact would give us sort of a black eye to the public if that were the case. The patient was instructed to use cool compresses, elevate the head, no activities, and call with any changes. The office did check back 2 hours later, and the patient indicated that still having problems and hadn't really improved at all, and was asked to come in the next morning for evaluation. That next morning, there was ongoing pain, headaches, swelling, can't open the right eye, periorbital hematoma. IOP was only 25, and there's no documentation of the vision. The diagnosis was that the IOLs were in very good position. There was no problem. The plan was for some Xioptin drops and to return in 2 days. On post-op day 3, the retina was flat. The vision in the right eye, unfortunately, was only light perception. The patient was sent to retina. The retinal evaluation indicated there was some optic neuropathy of unknown etiology. The patient went on to have NLP vision. Of course, we're very well aware of what likely happened was a retrobulbar bleed in this particular case that caused pressure on the nerve, decreased visual acuity, pain, hematoma, other issues. And of course, those types of things can occur, especially in a day and age when we have so many patients that are on anticoagulants. The allegation when the claim was made was there was a failure to timely evaluate the post-op complaints of the patient who received the retrobulbar block, resulting in vision loss due to a hemorrhage. Patient did file suit, obviously, demanding $1.5 million, and the case settled for $750,000. The poor documentation of the postoperative visits, especially in that first day when something perhaps could have been done to help the patient, there is no sense of urgency apparent there. And of course, all of these are being handled by COA. And again, I would stress the fact that we have the same problem in several of these cases, which is that you're having other individuals help with the postoperative care, and that they should realize that what is occurring is not normal. It's not typical for your particular practice, and that they should call you immediately should there be anything out of the ordinary, at least allow you the opportunity to talk to the patient or make some decision as to what should go on. The declining vision by post-op 3, day 3, when referred to the retina specialist, is a little bit too late. The retrobulbar hemorrhage should have been suspected at the initial call, especially given the swelling and black eye or ecchymosis that had occurred at that particular time. The patient should have likely been seen on the same day. Of course, even at seeing him at 5 o'clock, I'm not sure that anything could have been done to help the patient, but certainly there was an opportunity to save some of the vision at that particular time. The question is causation. Even if the patient was seen, and the defense expert even opined on this, even if the patient was seen following the 5 p.m. call the day of surgery, it's uncertain if vision could have been improved. The risk management issues were documentation, the post-operative visits, the post-operative phone calls with the staff, and the telephone screening problems. Again, I think it's important to develop good protocols of when to contact the physician. And on top of that, should be of that list, should be if there's anything out of the normal, anything unusual, the surgeon should be notified immediately. There's certainly some telephone screening protocols that have been developed by the Omic organization and are available to anyone to obtain and try. There's no indications that the surgeon really understood what was going on. There was on the first postoperative day, no indication of the patient's vision. It did indicate there was increased pressure. We would hope that it was not normal for this individual's patients to come in with black eyes and swelling. And so you would have hoped that there had been a differential diagnosis formed at that particular time. And perhaps being able to save some of the patient's loss of vision. The sparse notes, may be misconstrued by jury as to patient being too rushed, not very thorough, or lack of knowledge. Again, it's important to develop good protocols for telephone screening, both after hours and during office hours, so that the patients can be taken care of. And, many times by simply saying to the surgeon, here's an issue, here's a problem. Is there anything can be done to help? The surgeon's put in a position where they can at least communicate to the patient and or see the patient if necessary and intervene before worse things occur. Good. And certainly we have opportunities to get resources like telephone screening and ophthalmic surgical checklist and the AO guidelines for co-management. Thank you very much for attending tonight.